a function of our society's view of healthcare. It's a reactive rather than proactive state of health. So some of the patients who come to our practice tell me that, well, I never see my doctor. I'm not sick. So they're potentially not even going to like a functional medicine doctor who also, even though they're looking for root cause, they're still looking for root cause of a disease process, right? What I'm looking for is a patient who says, I feel amazing. I'm 42 years old. I want to feel amazing at 82 years old. How do I get from A to B?
Hi, today we have Dr. Brittany Busse, the Director of Women's Health at Velocity Health. So, why don't you go ahead and tell us a little bit about how you got into medicine and your background story?
Of course. So I am probably like your typical like doctor. Like I wanted to be a doctor since I was a kid, and I really did. Like it kind of transitioned over the years from like I really wanted to be a heart surgeon. I thought that was a really cool job, or a brain surgeon, and then I thought that maybe that was a bit too bloody for me after kind of seeing them and not in person, but there wasn't internet at the time, so you were kind of restricted as far as like what you knew about what surgery looked like. I think I saw like a veterinary surgery one time at the state fair, and I was like, ooh, maybe not. And then I wanted to do psychiatry actually for a long time. I had a very deep interest in how people kind of approach the world, how we process information, how that leads us to perceive what's happening around us, and how that impacts our personal interactions. But when I went to medical school, I realized that like a lot of psychiatry was medication prescribing, medication tailoring, alterations, and it was a lot of just kind of throwing things at a dartboard pharmacologically and seeing what stuck. And not a lot of time was actually spent in that communication with patients that I was really craving. I really just craved a deeper understanding of patients and their motivations and their psychology, like why they wanted to do the things that they told me they wanted to do. But there wasn't really space for that in traditional medicine, right? And so I ended up back in surgery actually. And I wanted something that had very distinct outcomes, right? Like a patient would come in with a hernia, they would leave with no hernia. I was like, okay, like I can handle that. That seems like something that I would like to do rather than, again, medication tailoring administration and just kind of having patients return over and over and over again for these short visits where it seemed like nothing happened. And you weren't creating relationship. The doctors didn't even know their grandchildren of the patient anymore, and that was that kind of old school perception I had of doctors was they know everything about you, they know your family, and they tailor your health accordingly. During my training, I had a bilateral retinal detachment. It's probably genetic. Really, nobody knows where it came from. I was 29 years old. I had had significant harassment occurring in my program, and after several months of recovery, they were demanding I either returned full time, which I was unable to do, and they knew that, or lose my job. So I said, okay, well, I guess I'm gonna go. So we call that unattended attrition in medicine, where I started off with a residency and was unable to complete it. So I completed 4 out of 5 years of training, and then was left uncertified. Or, in medicine, it's really like assigning yourself to a box. Like I'm a surgeon, I'm a primary care doctor, I'm, cardiologist, I'm this, I'm that. Um, and what I found was there was a lot of freedom in that. I could really focus in on what called to me as a physician in medicine. I started working in telehealth in 2016 because I loved the amount of FaceTime that afforded me with patients. I felt like a lot of time is set aside for the physical exam, where during many physical exams you don't learn much more about the problem than you learn from a good history. And then when you're doing a treatment plan, you need to be able to sit down and explain to the patient what's going to happen, why it's going to happen, and all of the risks and benefits of that, and give them a choice and an opportunity to ask you questions. And in a 15-minute appointment, you can't fit all of that in, right? Like how are you going to fit in history taking and physical exam and treatment planning and questions and all of those things? And most patients end up leaving appointments just feeling like they got completely railroaded by the physician for good reason. So the more I explored my options in telehealth, the more I found that those interactions could be driven by myself and the patient, and that patients were really interested in having more data, having more autonomy in their health. And so we started really honing in on like a preventative precision medicine and longevity medicine space where patients are really curious. They really remind me of myself in that way, in that they want more information. They want you to tell them all the details, everything you're learning from the studies, um, everything they've heard, and they want to get your take on it. And I have the opportunity to spend up to 90 minutes with them answering their questions. And I spend the rest of my time researching and learning and developing protocols um, that put patients at the forefront of their care, that put them in the driver's seat of care. And I absolutely love that, and especially for women who have felt very much like the medical community has been gaslighting them for decades now. To put women in the driver's seat of their own health is just such an amazing opportunity for me, and it feels empowering to me as well as for them. So that's where I am.
Super. Well, thanks for that background.
Mhm.
Maybe you could tell us who the typical patient you see is, like your age and maybe what conditions they may be dealing with.
Yeah, so probably most of the patients who come to me are older, more established patients, and established like in their career, because we are a concierge practice. These women are driven. They are wanting to stay on the cutting edge of their careers, of their health, and many of them are facing perimenopause and menopause. And we know that many women feel like that puts them at a disadvantage in the workplace because of the neurological effects of perimenopause and menopause. So women are looking to be proactive about their health. I've also met with women who are in their 30s, looking at fertility planning. Again, very driven, career-focused women who want to have children and are, hearing that they're too old. And maybe that their body won't work as well for them. So they want to know, what can I do? Where am I in all of this? And how can we be, again, proactive? And what does the current research say about what are my chances for naturally um, conceiving and having children? So I would say that that's probably the majority of women I work with, like fertility through perimenopause, menopause, and just helping women achieve that optimized long-term health outlook that they're looking for.
Recently, there was a some talk about making hormone therapy more available to women. Any thoughts on that, and how does that play in with some of the types of patients you described?
Yeah, so women are coming luckily earlier to us for hormone treatment. What we have found and what the research shows is that the studies like the Women's Health Initiative were conducted mainly on women in their late 60s, those who had already developed conditions like predisposing them to cancer, to heart disease, and that bringing hormones into the picture after disease has already developed was actually a negative for women's health. So there's a theory that there's a period in which the continuing to provide a woman with hormones will continue to provide them with the benefits, but you will have disease progression, and that reintroducing hormones may actually cause a detriment to women. So there's kind of like this latency period. So luckily, women are getting that information and coming a lot sooner for evaluations, again, even into the perimenopause period where women experience a lot of erratic hormones leading to symptoms that are really disruptive, like disruptive sleep, irritability, memory, short-term memory loss, weight gain, a lot of things that are difficult for them to manage without somebody getting a look at what's happening with their hormones. And they're hearing from their primary care doctor, usually like your hormones are normal. So they're getting a one-time test of their estrogen, progesterone levels, and since they're not in menopause, the levels are normal for a woman of that age, and they're saying no intervention needed. When what they really need is hormonal stabilization. So women are coming and they're looking again to be more proactive, to understand what's going on in their bodies, rather than just to have very cookie cutter analysis of what's happening.
And is there an approach you take? What's the best approach you think to take to get to better understand that's going on with the women's hormones,
I think
both
it's
both
really
currently
taking
as well as monitoring?
Yeah, I think it's really important to first of all understand what are the symptoms that the woman is experiencing. We've all heard hot flashes, night sweats, and irritability potentially, but it's really they're a lot deeper than that. I think most women come to you saying, I don't feel like myself. I don't know what happened, but I turned 42, 44, 45, and I don't feel like myself anymore. I woke up with joint pain, heart palpitations, anxiety, reflux, allergies that I never had before. Like, what is happening? Like, what is going on in my body? And almost every single tissue in your body is sensitive to estrogen. So whether you have too little estrogen or too much estrogen, your body is going to be experiencing different symptoms at different times in your cycle. So what we do with women is really talk to them about the symptoms. We have a full symptom chart that they can take a look at, and they're like, I didn't know that I have that, but nobody ever told me that was possibly related to my hormones. And then they're able to track that as they start having treatment. We track not only any negative effects that they might have to treatment, but also any positive effects that they're having as in the lessening of symptoms. Because especially in perimenopause, again, there's no lab you can really track. We do some urine testing, Dutch test, it's called dry urine analysis. That sometimes can show you a pattern of too much estrogen and too little progesterone, which is common in women transitioning in perimenopause, but not always. It doesn't always show you a clear pattern. So we do base a lot of it just on symptoms and having women track their symptoms and their cycles and tell us what's going on. So I think above all, it's just taking an active interest in that patient's life and how their symptoms are impacting them.
How often do you get to see your patients in a given year on average?
I meet with them at least 4 times a year.
Okay.
For usually about the first visit longer, like an hour plus, and then the follow-up visits usually between 30 minutes and 60 minutes, just depending on what's going on.
And you're primarily a telemed practice,
100% telehealth right now.
100%. And how do you overcome the challenges of what physical types of appointments need to happen?
Yeah. That's something I've been dealing with since 2016, right? When I first started in telehealth, I actually did a lot of occupational health. So people would often ask me, like, how do you assess injury in a patient that you can't put your hands on? And my response was, have you ever examined someone with a sprained ankle? Usually they bring the extremity to you and it's swollen and it's painful, and you say, okay, I'm going to touch that now. They go, no, 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 no. Like, you are no, 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 don't touch that. That hurts. That hurts if you touch it. I know because I have touched it. Right. And so I think when you're in this situation, or I know when you're in this situation, you can just ask the patient, right? Like, hey, if you press on this, does it hurt? And if you turn your body this way, does it hurt? And I can obviously see the person. I can see if they're grimacing. I can see the interaction that we're having together just as well as I could. There's really nothing that is given away by placing your hands on a person that you can't get from talking to them. I mean, even, we saw yesterday in the Super Bowl with all the tight ends, right? Like, you don't need to have a physical examination of your prostate anymore. Like, we've done away with the physical examination of the prostate that makes you uncomfortable physically, emotionally, mentally. And it's just a blood test. And there are many diagnostics that exist that didn't exist potentially even 20 years ago in medical training. Or if they did, they've gotten so much better in terms of how specific they are for the disease process that we're looking for and how sensitive they are at detecting those things. So much more sensitive than a doctor's doing a physical exam. Again, at least in my experience, I think many doctors like to argue, I think unless you're an orthopedic surgeon, and you really like understand like the translational capacity of a knee and a tibia on a femur, most doctors don't. And so at the end of the day, there's so much that we can gain from observing the diagnostics, and we're doing a lot of advanced diagnostics with patients. Again, we're doing genetic testing. So there was recently a study published in JAMA called the Wisdom Trial that looked at genetic risk for breast cancer and stratifying patient screening based on that. And what they found was that there was no increase in breast cancers for low risk patients who deferred a mammogram. And they determined risk based on a genetic profile and also a yearly questionnaire, which included personal history, family history, etc. And they found that there was no increase in breast cancer using this approach. So we're able to take information like that and incorporate that into our clinic because many women in their 40s, they still have very dense breast tissue. And they complain a lot about mammogram not being um, adequate. So then they end up going for ultrasounds or MRIs that they potentially don't need because they're very low risk. Whereas somebody who is very high risk genetically, if they have a certain profile that we can determine pretty easily nowadays, they might need an MRI versus a mammogram. So we're better able to tailor the diagnostics that people need. And then we do a lot of care coordination. So we have a whole team of individuals who are involved in care coordination, both for like routine things like body composition scanning, coronary artery calcium scanning, and then more advanced diagnostics like breast cancer detection and surveillance.
And do you deal with the whole body, or are there specific parts that you deal with?
No, we are a holistic clinic. So much of medicine is just putting people's body parts into buckets and not looking at the overall picture. So if I'm talking to a woman again about even hormonal health, I'm also testing her GI tract and looking at the types of bacteria that live there because there's a whole part of your microbiome called the estrobolome that affects estrogen metabolism. So I'm looking at how your liver works. I'm looking at how your microbiome is interacting with those things. I'm looking at your hypothalamic pituitary axis and your stress levels and how, the HRV can affect the symptoms that you're having. So heart rate variability can be a sign of parasympathetic and sympathetic activation, and that has a whole implication for your hormonal balance even. And so you can't just take something like this in a bucket. I think so many of these online programs are still very much based in the old model, right? So there's some great programs out there trying to improve access for women, but they're just focusing on one aspect of being a woman or a person in general. So you're looking at like, oh, I just get my hormones managed from this website, and I get my weight loss medication from this website. And then when I need something for the migraine headaches, I go to this doctor. And when I need something for my GI tract, I go to this doctor. And nobody's really combining all of those things together and realizing that they all impact each other, or even asking the questions that would help you take a whole body picture. So we focus on not only the physical, but the emotional, mental, the social. I even love it when my patients share esoteric spiritual practices with me so that we can incorporate those into their planning. So I have some patients who are like, I'm preparing for a medicine journey and I'm going to be fasting. Like, what can I take? What can I not take, of my supplements, or what should I add? What should I take away? So I think having an open mind about what patients are putting a priority on is really important as a doctor. Like, you shouldn't come to them and try to tell them what to do. Like, I'm here to just guide them on their health journey. I need to be there to support them. And if I take a very judgmental attitude towards something that they're doing, then they're not potentially going to respect my opinion on the rest of their health and lifestyle.
I love that. It sounds like a practice that I'd want to see, because it sounds as if you're giving answers to a lot of issues and tying it all together, versus, as you described, going out and seeing one doctor for this and one doctor for that. Um, how does one make that available to a more mass market opportunity?
I think where we're focusing or choosing to focus is that the, there's a lot of what we call N of one, right? So every person is essentially their own experiment, both physically, emotionally, mentally, right? And so where we see that becoming more potentially broadly applicable is that the more iterations you have of N of one, you could actually start getting pieces of that into other individuals as well, right? So if I'm made up of A, B, and C, and you are X, Y, Z, and then this other person comes in and they're A, Y, C, well, I have information of all those components. So it's really taking advantage of AI and culminating a lot of data and then seeing where we can use that to create personalized profiles where rather than just like, oh, your labs all showed this, this, and this, and evidence based is like, this works for 90% of people, therefore you probably fall in that 90%. So we're just going to give you what they worked. And then if you're in the 10%, you go, but this doesn't work for me, right? And so there's not a lot of wiggle room for that. Whereas this is more of an evidence informed approach where we take what's working and what's not working, but we look at the characteristics of each individual that it is working for versus not working for, and we're able to come up with a more informed plan over time, right? So it's one of those things where it starts out potentially elitist and costing a lot of money because you have very few people participating in the data set. But then over time, as the data set grows, it becomes more widely applicable.
And it becomes sort of proven science as to how to deal with these issues.
Correct. Yeah. So again, it is really a paradigm shift, right? And I think we're seeing a paradigm shift in many realms where people were saying, like, okay, like there was population health or public health, and we're saying, like, okay, we made all of these decisions on rules and regulations based on public health or population health outcomes, looking at the lowest common denominator as far as like what could we get people who don't have access to resources to do in order to help them have better health. And then the people who did have access to resources started fighting back as saying, like, well, that doesn't apply to me. Why am I being told the same thing that everybody else is being told? And you're like, well, you have to understand, like, this is for the broader population of people to keep us healthy as a community. It's like, well, no, I want to know what applies to me as an individual. And our corporate structures and governmental structures are not set up for individuals, they're set up for populations. So that's a huge paradigm shift that we're seeing happening is people want more focus on the individual and less focus on the overall population.
What's your thoughts on wearables and the role that wearables plays in your practice and the future?
Yeah, so wearables can give you a lot of data, sometimes to the point of data overload. I know sometimes even my Garmin gives me anxiety, right? Because it's like, your HRV is low and your sleep is terrible. And I'm like, I'm sick, like, stop yelling at me. Um, and I feel like a lot of people feel that way. So sometimes it's better just take it off, right? If you know you're not in your best health right now, maybe it's better not to have your device yelling at you when you know you're doing everything possible to get better. I think it's a really good tool for people to use when they're not doing everything possible to feel better and they're starting to introduce new things, especially like advanced wearables like CGMs. So a lot of people potentially know what they are. It's a device that measures your glucose or your blood sugar levels on a continuous basis. Unfortunately, most people don't understand how to interpret it, and they end up looking at the peak values and thinking, "Oh my gosh, I'm fruit intolerant because when I ate a piece of fruit, my sugar went up." I'm like, "Well, no, that's what your body should have done." But luckily it came right back down because your insulin level then also went up and your body got rid of the extra sugar or put it away for fuel for later, or you peed it out, or whatever you needed to do. And so people start making interventions in their life that are actually harmful. So I've seen patients like almost completely stop eating to flatten the peaks on their CGM to the point where their overnight blood sugars are in the 30s.
Hmm.
Uh, and you're like, no, 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 that's not correct way to do that. So I think the data itself without a guide to help you tailor the interventions to what's happening in your body um, can lead to negative consequences for individuals. So it's really important to work with somebody if you don't understand, I'm sure there's, plenty of people out there who are intelligent enough to figure out what's going on with their CGM and can look at the data available and ask ChatGPT to help them interpret it maybe if they need to, and they can make adequate plans that way. But a lot of people really need a physician and a nutritionist and a whole panel of people who can help them interpret the information and then figure out how to make a long-term plan that prevents insulin resistance or reverses insulin resistance so that they can be healthier long term. Again, that's taking a whole bunch of data, not just your CGM, not just your Oura ring, and combining it together into a whole person picture. Again, including possibly a DEXA scan, including possibly a microbiome map. And looking at how all those things are interacting together so that you can get the results that you want. Because it's probably not just what you're eating, it's how you're digesting it, it's where is the fat located in your body. There's a whole bunch of variables there. But if you're only looking at one piece of data, you might be, again, missing the forest for the trees.
As you mentioned, a piece of fruit example,
Mhm.
uh, a healthier body is going to have a sugar spike, but
Mhm.
then come back down relatively soon. Whereas
Mhm.
somebody who's not doing as well, it may stay elevated for a while.
Correct. Yeah. So you're actually looking not, you're looking partially at the peaks, but also potentially the area under the curve. Right? So if you're coming up and coming back down, then the area is actually smaller than if even you're not coming up as high, but you're coming back down much more slowly, then the area under the curve is more. So you're looking to reduce that. So the overall time spent in hyperglycemia rather than just the level of hyperglycemia. It's a combination of both.
Gotcha. So the other day, I unfortunately had a little bit of a biking accident.
Mm,
I live in New York City, and I was riding my e-bike slowly, but I caught a little piece of ice and I slid out, and cracked a couple of ribs.
mm,
I will say it's intense pain, but I'm getting better. My Aura ring the next morning knew that something was going on, and it suggested to go into a rest mode, which
mm.
is so I don't get all stressed out about my
Yeah.
numbers. And each day it's kind of letting me know there's some minor or major signs of something going on. And it wasn't really even based on anything I inputted, it just based on having all my data, which I thought was really powerful.
Yeah. And that is definitely something that's really helpful. Again, like even something like Garmin, depending on the algorithms, it's usually looking at your heart rate variability a lot of the time, or even just like your resting heart rate. So when your body is under stress, and your sympathetic nervous system is activated, your resting heart rate is going to go up, your HRV will potentially go down, which is the amount of variability between beats. And that indicates, again, a higher sympathetic state. So it might tell you to do things like avoiding too extreme of exercise, getting more sleep, getting more rest, not drinking alcohol. But it was not going to tell you that, but potentially you'll know that so
Yep.
that you can get better quality of sleep. Because yes, it's tracking that when you're in pain you're going to be at a much higher level of activation, right? People have pain, their heart rate's probably going to be in the 90s to 100 if they're a healthy person. If they're an unhealthy person, maybe like 110, 120, even depending on the amount of pain that they're in. And your wearable is sensing that. It's like, wait, why has Rob's heart rate been 100 all day when it's normally 60? It's
Yep.
like he's either sick or there's something else going on that's stressing him out and doesn't know exactly what that is. Um, but it's saying like there's sympathetic activation there.
So, by the way, I'm going to go back and look at my heart rate now and to see
Yeah.
what was it, how elevated was it after the
Yeah, when I
accident?
was sick the last couple of weeks, I'm very interoceptive, as in I can kind of feel when something's going on in my body, like higher heart rate than normal even. Like I can have a pretty good if I rest, I'm like, oh yeah, my heart rate's probably like 65, and I can check my watch and it's usually pretty close. But I was sitting and meditating and I was like, why is my heart rate in the 80s and 90s? I'm
Hmm.
meditating, right? And I looked at my watch and sure enough, it was like 97. I'm
Hmm.
like, that doesn't make sense. And so um I just knew I wasn't feeling well and I was coughing, but I thought it was maybe just a post-viral type cough. But my heart rate was actually getting higher, not lower. So I went and got checked out. Turns out I had pneumonia. Like
Hmm.
no other indication. Didn't have a fever yet, right? But I got it checked out pretty quickly after that. I did have the coughing and shortness of breath, but I'd had that for over a week at that point. And it just kind of tipped slowly over from a post-viral syndrome into a pneumonia. And if it weren't for that realization that my heart rate, and I wasn't recovering either. My watch kept telling me, and I wasn't exercising, but my watch kept telling me like, you need 20 hours of recovery. And I was like, why? I didn't do anything today, you know? So the algorithms are really good at detecting deviations from baseline if you use it continuously, right? But it's not going to be able to tell exactly what that deviation is. That's where you're going to potentially need your own intuition or history to know, like, oh, well, I fell off my bike and I know my ribs are cracked because they're incredibly painful, versus I know I've been sick, but suddenly I am potentially more sick than I was a week ago. So you have to be able to take that information. And if you aren't really able to understand that information, it's always great to have a doctor on call, right, who can get that information to you right away. We collect the data from our patients on their Oura rings, CGMs, et cetera, and can usually tell right away, like, hey, there's something going on with this patient because they're way off their baseline.
And is it typically proactive in a sense that you guys monitor it, or is it when the patient comes to you and says, "Hey,
Yeah,
I'm
I
not
think
feeling well"?
Yeah, we're working more in the integration side as far as like monitoring it. So what we do even with my technology company is working with patients who are on Medicare, and we are continuously monitoring, at least on a daily basis. Not they're not wearing it all the time, the sensor, but they're taking their blood pressure every day. So we're able to see changes. And for a long time we've known patients with diabetes, when they get sick, their baseline blood sugar goes up. But a patient wouldn't know that because most type 2 diabetics aren't actually checking their blood sugar every day. So most patients wouldn't know that, and they would suddenly feel ill on top of potentially having a virus, and that is going to increase the inflammatory state of their virus and potentially, or of their body, and potentially make the viral symptoms worse or put them in the hospital, as we saw a lot with COVID, was people with chronic disease um, weren't alerted to the fact that they were sick early enough and their body went into systemic inflammatory response. If you can see that happening earlier, you can intervene earlier on that. So we want to be proactive. Again, that's a function of our society's view of healthcare. It's a reactive rather than proactive state of health. So some of the patients who come to our practice tell me that, well, I never see my doctor. I'm not sick. So they're potentially not even going to like a functional medicine doctor who also, even though they're looking for root cause, they're still looking for root cause of a disease process, right? What I'm looking for is a patient who says, I feel amazing. I'm 42 years old. I want to feel amazing at 82 years old. How do I get from A to B? And how are we going to identify the changes that are happening subtly over time and intervene early on those things? And how are we potentially going to look at what your genetic profile is and intervene long before symptoms develop? So maybe you never even develop any symptoms. So I think even what we would call extreme proactivity can be the norm for people. Like, why ever wait until you develop heart disease? Why wait until your calcium score is 10 even? Let's keep it at 0 for as long as possible. And what are the things that we need to do now? Like, how is your body processing calcium? I'm sorry, cholesterol? How are you making it? Are you absorbing it? How do we keep your levels normal? What is your inflammatory state so we can prevent damage to your blood vessels long term? All of that stuff can be looked at in an extremely proactive manner. And then again, people can use the wearables to detect early deviations from baseline, and maybe it's something acute. Or maybe again, like with what we see with women in menopause or even perimenopause, is estrogen affects your insulin resistance. It affects your muscle mass. It affects how your body processes cholesterol. So heart disease and diabetes suddenly spike in menopause, all because of loss of estrogen. So how do we intervene on that earlier and keep patients from becoming ill in the first place?
So you mentioned genetics and the role in genetics in your practice. Do you put all your patients through genetic testing, or have they already done that?
Yeah, so we do use baseline genetic testing for our patients. It looks at a variety of different risk factors for cardiovascular disease, neurological disease, but even things like nutritional profiles. So some people might say, like, I did terrible on a vegan diet and I did really good on a keto diet. Well, that can actually have a genetic component to it, depending on how your body processes saturated fat or cholesterol, or what your baseline caloric needs are. And so, by looking at those factors, and also some people build muscle really easily in regards to minimal stimulus, where other people store fat really easily in response to a minimal stimulus. And that's important to know when you're designing a nutrition, especially a long-term nutritional plan, not something that's like, oh, a short-term weight loss plan. Like, you want to know, how am I going to eat long-term to maintain my health? And I'm going to want high muscle mass and low visceral fat. Well, that's going to be a completely different eating pattern for different people depending on their genetic profile. So we have a pretty standard genetic test that we use that gives us a good, clear picture of potential deficiencies, liver pathways, right? Some people are high detoxers, where other people's detox pathways are genetically sluggish. And that could have an implication for how your body processes hormones, how you process heavy metals. So you might have mercury toxicity at a much lower level than someone else can eat tuna every day and they're fine, and you eat one a month and you have high mercury levels. So, really understanding how we interact with our environment and how that can cause disease is important for long-term health.
So that leads to the question, genetics or epigenetics as a deciding factor.
Well, then it becomes both, right? Because I think if you have this propensity, we know that both, it's a both and. Genetics are not um, a life sentence, right? So people will take Alzheimer's, for example. You have this gene, ApoE. It's actually a type of cholesterol that's predominant in the brain. There's three different types of ApoE, two, three, and four. If you have two, you're less likely to get Alzheimer's. If you have three, you're average. If you have four, you're higher risk. It's just a misfolding of the same proteins. So when patients present with ApoE4, you can have 3, 4, 2, 4, 4, 4, and those with 4, 4 are genetically at the highest risk. That's not deterministic. That doesn't say that everyone who's 4-4 is going to get Alzheimer's disease, but based on how you eat, like how much saturated fat you're getting, because anything that impacts your cholesterol is going to also impact your risk for Alzheimer's disease in this case. So we want to put you on a very proactive diet and exercise regimen to make sure that we're maintaining heart health, which is the easiest thing to track, right? It's not very easy to track right now. The development of Alzheimer's. I think you can do it with a lumbar puncture, which most people are not signing up for because it's dangerous and painful. Or they are developing blood tests for early detection. They're not widely available. They're not what's called CLIA certified, which is a lab standard that labs have to use, but there are research labs who do it. So it's, again, having that understanding as a physician of what's available, what's coming, and then how do we proactively manage something like this? Because again, it is epigenetic in that sense that you have a risk factor gene, but if you take out all the environmental risk factors, you actually end up lowering your overall risk. So patients who have ApoE44 shouldn't feel like, oh my gosh, this is a death sentence. I'm going to get Alzheimer's just like my grandfather, just like my father. And there's nothing I can do about it. Like, there's tons of things that we can do about it proactively, just when it comes to managing your health, and other ways that we can keep that from becoming an active risk factor, right? So
Is
lots
there
of fun.
sorry, yeah, is there a diet that, in that case, in that example you gave, even if it's just one APO E4, do you have a specific diet that you'd recommend in that case?
For most people, again, it's where it helps to kind of have this genetic profile as well. And we do something called the Boston Heart Test, which also tells
Hmm.
me a lot about cholesterol, whether you're a high absorber of cholesterol or a high producer of cholesterol, because that might make a difference for whether we want to use pharmacology, in order to manage your risk as well. But as far as dietary guidelines, the most studied would be what we call the Mediterranean eating plan, and it just happens to be high fiber and then low inflammatory proteins. So things like chicken and fish, they don't contain as much inflammatory factors like L-carnitine as beef. It's not saying that beef is bad. It's just certain people who have a lot of L-carnitine, have a lot of saturated fat, are going to be more prone to inflammation and long-term damage. Not true for everyone. Obviously, there's people out there eating nothing but steak who feel like supermen or women. Um, but again, different people are going to respond differently. So we can trial certain eating plans. Again, this is evidence informed, not evidence based. So there might be a number of studies that recommend this Mediterranean eating plan, or I forget what it's called, but it's basically it's a variation on Mediterranean. It's a brain health diet. But it's again very high in phytonutrients, higher in fiber, all whole foods, right? We're really focusing on not processed foods. I think that's the low hanging fruit, I think, for most people is that lower processed foods, lower sugars. Um, you're going to get the most bang for your buck. High olive oil, nuts and seeds, getting your fat from natural sources is the most important thing, and making sure that it's primarily omega-3 fatty acids, omega-6 fatty acids in balance. And we're testing that as well, what your omega-3 to omega-6 ratio is. And then again, depending on your genetics, you may need to reduce your amount of saturated fat that you take in, which is going to mean reducing red meat, reducing animal-based fats like dairy, butter, tallow, all of those things. Again, not saying that's bad for everyone, but there are some people for whom that's not a healthy eating plan, and knowing if that person is you is really important. So, anytime we do an intervention, we know exactly what we're going to measure after that intervention to ensure that we're getting the results that we want and in the short term, right? Because we can't project 20 years into the future. All we can do is take the log of the data that we're getting and say, like, okay, you are on a good course to keep this flat over time rather than to have a sharp incline in your heart disease risk or your Alzheimer's or brain health risk.
Yeah, that's great. I love how you describe that. You're taking in the data, including genetic study, how certain foods impact you, and then based on that and other factors, you're coming in with a plan that this is what's going to work best for you, but still subject to change once
Oh,
more data comes in.
yeah, and you're talking to individuals as well, right? I mean, it's difficult for me to come in and not understand what a patient's lifestyle is, right? I talked to someone the other day. I actually have a couple patients who are Orthodox Jewish. And having that weekly family Sabbath dinner is very important to them from a social standpoint and an emotional standpoint. And there's not always a clear choice. Like, I'm not going to abstain from dinner with my family because I'm on this really restrictive diet plan. And so it's really just factoring in, like, we know that longevity is greatly impacted by um, your overall, like, abundance of social connection, like how emotionally healthy you are, and connection's a really big part of that. So if we're doing things that are now going to isolate you from social connection, that's going to be detrimental to your health long term. So I need to know from my patients, like, what are your top three non-negotiables when it comes to your health, and how are we going to build these in by being flexible, right? So we're going to do 90%, and maybe we have to strive harder on the other days to hit these goals so that when you have a flex meal, you're not derailing the whole train, right? And people need to know what is most important to them, and having a clear understanding of the patient's short-term and long-term goals, as well as their social and mental health priorities, is incredibly essential to that relationship for me and for my patient. Because otherwise, in 6 months from now, they're going to say, I'm not doing this anymore, right? Like, this is negatively impacting my life. I don't want to do it anymore. And so we haven't if we don't plan, right? What is it? You fail to plan, you plan to fail. So if I don't know that that's something that's important to my patients, we don't have a flex plan in place, then they're going to end up hating the plan and it's going to fail.
Yeah, I love that. Tell me if you could wave a magic wand, what would you do to change healthcare in America?
I would make sure that people understand that when you pay a physician to work with you, that is the number one driver of your health satisfaction, right? I think so many people who are dissatisfied with healthcare the way it is, who want to blame their doctor who's only spending 15 minutes with them, they're not prioritizing that. They think I'm putting $1,600 a month towards insurance, mostly so I can say I never see the doctor or things are kind of getting out of hand underneath. And it's really when you pay a professional directly, that's a sign of a relationship, right? That would be me and you making a handshake agreement that I am prioritizing you, you're prioritizing this relationship with me. We're both now invested in it, right? When you put in all these middlemen into your healthcare between you and the person who's delivering, you're going to be dissatisfied and you're going to have poor health. That is my number one belief is that the better, the more you value your health with your pockets and your money and your expenses, like the better your health is going to be. And that usually involves a one-on-one relationship with a doctor. It doesn't have to be a high-end concierge longevity doctor. Um, it can be a DPC doctor who direct primary care. Their fees are typically, you know, 80 to $120 a month. They're available all the time. They often answer texts and emails. They're not doing diagnostics potentially the way that we are, but their visits are longer and they're person focused because they want to have that relationship with you. You are the lifeblood of their business, and that means a lot to them, and you mean a lot to them. So your priorities become their priorities, unlike a healthcare, corporate healthcare system where actually the sicker you are, the more money they make off of you. So it's a perverse incentive.
So, a few last questions for you, some hot seat questions. GLP-1s, something you like, dislike, a bridge, or a long-term solution?
Um, Again, it's a personalized approach. I think that it depends on the person's goal. Depends on what they've tried in the past. I think that the standard dosing is based off of people who are incredibly unhealthy. So the more metabolically unhealthy you are, actually, the higher dose that you need to have a peptide be effective. So for patients who are more metabolically healthy, they often can get away with a lower dose, which means lower side effects. And if it doesn't include a plan to recognize how the medication is impacting you, again, this is where we get into like interoception and like the mentality around the medications. If you are using a GLP and you're very nauseated, it's very likely you are eating very dense foods, like calorically dense foods, that the drug is trying to tell you you don't need that much, right? And so you can actually carry that over long term. So if you start tailoring your eating plan to adjust to the side effects of the GLP medication, I think those people actually get better long-term results. Whereas those people who are just like, no, I eat until I vomit, and I'm vomiting so much I can't eat. Well, you're essentially just starving yourself. And you also need to go into it with a balanced protein plan, a balanced exercise plan. The worst outcome I've seen is patients who are very obese, who have unhealthy muscle mass at baseline, very fat infiltrated. They go on a GLP and they have muscle wasting to the point where they become immobilized, right? They can't even stand up on their own because they've lost muscle so quickly. Because muscle is a metabolically hungry tissue. If your body thinks you're starving, it will offload muscle and it will continue to keep fat and or add fat because that's a fuel storage mechanism. So if you're starving, you need fuel for later. Muscle's metabolically healthy, it will offload it. So you need to have a balanced approach that lets your body understand that we're not starving. Um, we're taking in still sufficient calories, again, a very high dose where you're having diarrhea and vomiting constantly is going to really nip you in the butt when it comes to that long term. And you need somebody who's going to make sure that what you're eating will actually meet your body's energetic goals as well. So I think it can be definitely a part of a weight loss plan. Again, women respond very differently to GLPs, I found, than men. They're very affected by the what I call GLP anhedonia, which is an effect the blood has or the drug has on the central nervous system where it tamps down dopamine. So it tamps down the pleasure you get from eating, but it also tamps down the pleasure you get from everything else,
Hmm.
exercising, sex, reading a good book. All of the things that used to give you a good dopamine spike actually goes down. And it's been reported as depression and anxiety-like symptoms, but it's primarily anhedonia, which is loss of pleasure in daily activities. So unless you're prepared with a mental health specialist and a plan to counteract that, again, the drug is going to take a lot of joy from your life. So I don't think it's a bad drug, but I don't think it's the only thing. And I know a lot of people who fail GLPs, right? You can overeat on GLPs. It's uncomfortable, but you can do it. And without a partner and a plan, and not, you just go to whatever GLP clinic where they're just like, here's your dose, like, see you next time, like, hope you lose the weight. Like people fail and they don't understand why. And it's not a failure of the person, it's not a failure of the drug, it's just a failure of the support system.
So GLP-1s, from what I understand, they kind of mimic or imitate what would be like a lower carb, maybe even a keto diet. Uh,
I would say that's a simplification. So it's glucagon-like peptide is what GLP stands for. Glucagon is a countermeasure to insulin in your body, right? So when you're diabetic, you have very high insulin levels in response to high sugar. Glucagon typically um, puts that balance in the opposite. So it actually can reduce insulin. It also has GIP, which is another incretin type peptide. And then retatrutide, which they're testing and probably releasing this year, has a third component, which is actual glucagon. So these are peptides, they're secreted in your body in very low amounts. Like, so anybody telling you like you can increase natural GLP, you can to a point, but peptides are very short acting. They're only available for seconds to minutes in your bloodstream. This, however, is a derivative of Gila monster venom that is much more potent, hundreds of times more potent than your naturally occurring peptide and last much longer. So that's why you have to inject it because peptides, being a piece of protein, will be degraded by proteases in your stomach and the stomach acid undissolved. So unless it's encapsulated, like the new oral form of Wegovy, it's not going to get into your bloodstream the way that it's supposed to. So people need to be careful with any like gummies or like oral things that people are saying are like GLPs. They're not necessarily. So these peptides work in that way. They do make it so you have reduced gluconeogenesis, which is making glucose from your glycogen stores, reduced glycogen, so you have less ability to draw on those stores if you are straining your body. So they're not great for people who do endurance exercise that is primarily anaerobic. So it's great if you're just going to do zone two, not so great if you're doing zone four exercise or HIIT exercise. You're going to notice a significant performance deficit on the medications. Um, and anything else that requires glucose. So even, normal thyroid function and hormone production can require glucose. So we're noticing a lot of interesting effects, I think, that haven't been well studied. And so it all kind of remains to be seen how these peptides will affect people long term.
oh, wow, that's a tremendous answer. So my last one would be AI. The impact on the patient if they're using AI, and also for the doctor and the practice. What are your thoughts today and in the future?
I think it allows us to take a really large amount of information, and make it more easily digestible for, like, say, the everyday person. It is dependent, obviously, on how you ask the question. You can ask AI leading questions and get answers that are in alignment with what you have asked. So we definitely saw that with the original, I think it was like Maha report, where they had asked some leading questions of the AI, and the AI had actually made up studies to back up the position that the author had taken. So you can lead AI to hallucinate. It's not, it will make things up to satisfy your curiosity. So unless you're actually reading the papers that it's presenting you, you should always go back to the primary data source, right? And if it can't produce a primary data source, it may or may not be correct. So I think using AI to get down to a certain line of thinking can be important, but it's, again, not going to know the whole truth of what is happening, because it is tailoring the responses to what you've asked of it. So I think there's a lot of really interesting things we can do by taking large data sets and finding trends within those data sets that computationally are very difficult for a single human mind to do. Um, but we have to be careful not to let AI lead us down a pathway, essentially a primrose path of like, oh, it just keeps answering me in the affirmative. I must be a genius, you know? And I always knew this was what was wrong with me, but you've kind of led AI down a pathway to give you the answer that you want. So it is oftentimes hard to differentiate between the two, and that can be a dangerous place with any kind of type of technology, right? Is if we're just using technology to affirm our own perception and our own view of the world rather than asking it to broaden our knowledge base, then we're getting into a dangerous situation.
I do appreciate your time.
Of course. Yeah, we'll chat again.